EKG, there's basic facts about EKG. And so we start with this one, sinus rhythm. Okay, sinus rhythm is the basic one you can see. That means the EKG is normal. There's some facts before we look at the EKG about the EKG that you need to know. So this is the normal function of the heart. So this is the P wave. Then you have your Q, RS. Then you have the T wave. This represents the atrium. So it's an atrium depolarization. That means because the heart is a muscle, it's going to depolarize and then contract. Then after that, you need to repolarize again. Okay. We don't have atrial repolarization because it's buried in this PR interval. Okay, it's buried from here. From here to here, that is where it's supposed to be the repolarization of the atrium. Then it resets itself. But we don't have it. From Q and RS, so that is ventricular. So that's the ventricle depolarization. That means action potential is generated. Those are big words. In the ventricle, and the ventricle contract. Then the ventricle relaxed again as it received blood. And that point of relaxation, the repolarization, is along the T wave. So the T wave is the portion of the repolarization of the ventricle. So yeah, so the whole thing continue again back and forth. Depolarization of the atrium, depolarization of the ventricle, then repolarization, back and forth, and the heart contract back and forth. And this signal, electrical activity, is captured with the EKG leads. There's a little bit of something you need to know about the heart itself. How does this signal come? So if this is the heart, okay, I always draw it like that, you know. So this is the aorta branches. The heart is divided into 4, okay, chambers. This is the right atrium, right ventricle, left atrium, and left ventricle. There have to be a signal that tells the heart to pump. And that signal is in the right atrium. It lay just right side here is the SA node, sino-atrial node. This is the electrical pathway of the heart. Then from the sino-atrial node, it sends a signal. This is what controls the pacemaker of the heart. It pace the heart. This is the way I want to pump so that your sinus rhythm and your rate is between 60 to 100. Okay, so you keep on firing. When you fire, there is another node here. That is the atrial. You see, it's between the atrium and the ventricle in the septum. So atrial ventricular node, the AV node, is sitting here. AV node said, well, I'm not going to travel all the way down to the apex of the heart to give the signal. So it branches. Before it branches, it forms a bundle here. This is the bundle of ease. This is what we call the bundle of ease. And then it branches into the left and the right. So you have the left and right branch of it. So this is the right, and this is the left branch. And you continue all the way down into the apex, and it comes down up like that. And this is the what we call the Purkinje fibers. So this is how the signal keep on going, track its whole self. If there's any disruption, there's another signal coming from here. It's going to disrupt the whole thing, basically. Now, there's some numbers we have to know. Okay, numbers we have to know about the heart. And so that you can know if this is normal or not. So I told you this is the P wave, the Q is the one going down, the R is the one up, and then the S is here and the T. From here to here, PR, so the PR interval, it has to be between 0.1, I'll calculate it later, and I'll say 0.1 to 2. Okay. And then the QRS, the distance QRS from Q to here, it has to be at least less than 0.12 seconds. So this is seconds. So 0.12 to 2 seconds is from PR interval, and then QRS is has to be 0.12. How are they calculating it? You see this numbers? This, oh, where is blue? From this to this, there is 5 boxes, 1, 2, 3, 4, 5. Each little one, so these little ones, they are like 0.04. Okay, so from this is from here to here 0.04, this is 0.08, and 0.12. So you keep on calculating and calculating. So you have to add the little balls, one from each other is 0.04. So you can multiply. If there's 3 boxes, yeah, then you multiply by 3, 0.4 times 3. So you have to count the number of boxes. So that's these numbers. You just have to know it. I don't know how to, I can teach you. There's no clue about it. You have to know it. That little 2 boxes is 0.04. PR interval is 0.12 to 2, and QRS is less than 1.2. Basic numbers. When you see EKG, you have to learn how to read it. This is how I read it. I usually read it, so I'll show you guys. First, I don't look at anything because I know there's couple of rhythm. I want to know if the rhythm is sinus. So this is the R I told you. So I look at one R, I look at all the R's. Okay. And I count the bigger balls between them. From here, this ones, I start counting them and make sure they are equal. So we have like 1, 2, 3, 4. As you see, 4 in between this R to this R. 1, 2, 3, 4. Okay, 1, 2, 3, 4. 1, 2, 3, 4. So that means equal. There's 4 R's between them. There's 4 bigger boxes between them. Okay, there's 4. Okay. So that is the how you can make sure the rhythm is fine. So I have what? Normal sinus rhythm, because R to R is normal. Okay. Then I look, is there any P before any QRS? Is there any P? So there's a P, then QRS. P, QRS. P, QRS. P, QRS. P, QRS. So there's every P for every Q. So I've checked that. I've checked the rhythm is regular. I've checked that the P before every Q. Then I look at the rate. Okay, what is the rate? There's 2 types. There's one if it's 6 seconds. If they tell you it's 6 seconds strip, you do it different. If they don't tell you, then this is the way I do it. So I count the boxes between RR. So RR, there's 4. What I do, and out of that, you can calculate the rate easily. So it's 300 divided by 4. So this is close to, I think, 75. So the heart rate for this is 75. If they tell you this is a 6 seconds rhythm, all you need to do is calculate from here the R. So how many R's you have? You calculate the number of RR. So 1, 2, 3, 5 times 10. So 5 times 10. But this is not a 6 seconds rhythm. I did not say it's a 6 seconds rhythm. I just took a portion of it. So you can, but if they tell you this is a 6 seconds rhythm, you just calculate the number of R. Okay, 1, 2, 3, or the number of QRS, which is the same 1, 2, 3, 4, 5, and you multiply by 10. Right, this is not 6 seconds rhythm, so you can calculate the thicker one, how many is between 2 R's. So from here to here, how many is inside? 1, 2, 3, 4. 4, then 300 divided by 4, and that will give you the rate. So whether the rate is 100, 120, and then I look at the QRS. Is the QRS narrow? Yeah, it's a narrow QRS. So, and then you're done. So we're going to take that and take each of the rhythm and say, does it match what we say? Okay, so this is a rhythm they've given us. First, we want to check if the rhythm is regular or irregular. So that's my pathway right there. Is this irregular rhythm or regular rhythm? So I calculate my R's, what is between them. So here I have like 1, 2, 3. I have 1, 2, 3, 1, 2, 3. Sometimes it deviates a little bit, but you can eyeball it, or you can put your finger in it and measure from here to here how many lengths. So you have 1, 2, 3, 1, 2, 3, 1, 2, 3. This is a little bit off, but it's the same 1, 2, 3, 1, 2, 3, 1, 2. So I have a regular rhythm. So you can even highball it and say, oh, this look regular, right? Then I look for my P waves. I see a P here, P, QRS, P, QRS, P, QRS, P, QRS, P, QRS. You go and you continue and do that. So there's P and QRS easily. I look for my PR interval. Is this normal? Yeah, there's like 1, 2, 3 boxes. It's within that range, 1, 2, 3 boxes. So remember your P, it start from just here, and then your R. So 1, 2, 3 here. So 1, 2, 3 boxes. So it's within normal. I look at the QRS, 1, 2, almost like close to 3. So it's within normal because 0.04 times 3 is within normal limit. So I've had 3 check. Then you look at your rate. How many? This is no, I did not tell you it's 6 seconds. So I have 1, 2, 3. So 300 over, and this is almost like here, 300 over 2.5 or 3. So that's like over 100. Okay. But this rhythm, 1, 2, 3, it may be 6 seconds. I pick it up. It's a little bit too slow. 300. This is 100. It's not that close, but this is sinus rhythm. So it's a little bit, but it's in the sinus tachy form. So 100 is not that too high, but we'll take it for example. So this is sinus rhythm, but the rate is very high. So it becomes sinus tachycardia. Usually they're very close. It has to be greater than 100. This is most close to 100, but we'll take it out. Okay. Then when you finished, they ask you second level question. What usually causes this is infection, hypovolemic, somebody is dry, anxiety, or something like that. All of them can do that. The treatment for this is nothing. I call it nothing. Don't go and start giving them beta blocker. Number 1 treatment is what? Look for the cause. For the cause. So when they give you a rhythm and it shows sinus tachycardia, and patient is fine, they don't give you any information, I'm choosing an answer for looking for the cause. If the patient has fever already, yes. If he has fever, well, that can explain why he has sinus tachycardia. So you have to do a second level question. Don't memorize it. You have to figure out what causes sinus tachycardia, and then you'll be looking for it in the answer choice. Treatment, again, look for the causes. The second one is a little bit interesting. So this is what we call supra. The name is from the rhythm. So supra ventricular tachycardia. That means it's not a ventricular rhythm, it's just coming above the ventricles. That's why it's called supraventricular. We'll talk about some basic facts about it, but we do the same thing. The reason why we go through, we calculate for our R and R. R, R, R. When you eyeball it, you can see that the distance from here to here is almost the same. There's two bars, big bars. There's 1 and 2 here. 1 and 2, 1 and 2, 1 and 2, 1 and 2, 1 and 2. Some of them, they're a little bit, but if you subtract it, you see 1 and 2, 1 and 2. That means I have rhythm is sinus. I look for my P, I can't see it well. You know, I can see it, but they're dead. You can see most of them may be hidden because it's too fast. You see the T wave, I can see. So hidden, these are the key things you have to, if they want you to describe it, there's no P waves. There's P waves, but it's hidden within the T wave. So you don't see it well. Your QRS is like 1, 2, 3. So it's normal. You can see your well-defined QRS. This is classic for supraventricular tachycardia. And then you calculate your rate. There's only 2, 1, 2 bars. They did not tell you this is a 3 seconds rhythm. It's 6 seconds rhythm. So I'm just going to use RR as my rate. So 300 divided by 2. So this is like 150. So his heart rate is 150. So I have a regular rhythm with a P wave that is buried, a QRS less than 0.12, and a rate of 85, 150. This is supraventricular tachycardia. Few facts about this problem. I think sometimes it's good to understand what is happening. There's a topic foci. So something is firing. The SA node is not doing its job. So somebody is taking up over at the bundle of his. So it's firing. Something else is firing, and it's causing the heart to move faster. So the heart rate is like greater than 150 and above. And like I said, it's regular. And this is very common in children, people with anxiety. It can happen. The treatment, okay? First, when they come in, they will complain of palpitation. So a patient come in, complain of a palpitation. You get an EKG and you see this, but they look fine. They're sitting down to you. So it's not sinus tach. This is supraventricular tachycardia because the rate is like 150 and above. So what you do for the treatment, the first thing you do is this tachyarrhythmia, you have to have a branch point. Stable, unstable. Okay, so if unstable, you will see something we call chest pain. You will see B-sharp symptoms, chest pain, dizziness, okay, hypotension, diaphoresis, okay. They're basically showing signs of shock. Okay, so that's, you have to do something about it. Okay, doing something about it. But if they are stable, yeah, you have time to do your job. Okay, you have time to do something about it. So if they are stable, your first treatment is what? Slow them down. So you do a vagal maneuver. So this may be like a SATA question. What do you do? Vagal maneuver, that means you massage the carotid. Don't do bilateral carotid massage. You kill the patient. So massage, single massage, carotid, and that will calm them down. Or let them do a Vasava, take a deep breath and hold it in Vasava. That will give them the vagal tone will take over. Vasava is a form of vagal tone. So parasympathetic nerve will take over and slow the heart down. If it's the kid, you can put ice in their face, cold ice, and that will make them slow down and everything. This is usually working kids better. Okay. If this doesn't work, then your next treatment is this medication, adenosine. So adenosine is the treatment of choice for supraventricular tachycardia. This medication needs teaching and expect to get a question on it. If they ask you, it will be this kind of question because we use it all the time. So you got to tell the patient certain things that will happen. Before you give it to them, you let them know that their heart is going to stop. Basically, you stopping the heart and then resetting it. So there will be a brief stop of heart, and it's the most scary thing you ever seen as a doctor or a nurse. You give it to them and you see the EKG, the monitor become flat. And it's the most difficult 2 seconds, 3 seconds of your life, whether they're going to come back or not. So you have to tell them your heart is going to stop, and you feel like basically it's stopping. And so we have to do something, but we need to do this to bring you back. Okay? The administration of the medication is very important. The first dose is 6 milligram IV push. And they can ask you, what does it mean to do IV push? Well, IV push means you run it over 2 seconds. It's fast. 2 seconds followed by 20 ml of saline. You give it IV and you just slam it in 1 to 2 seconds and you flush it with 20 cc. And you have to choose a vein that is closer to the heart. So vein closer to the heart. These are SATA questions you expect that. These things, telling them their heart is going to stop. Do it over IV push, 1 to 2 seconds. Use 20 cc of IV flush. Give them 6 milligram of adenosine, and then choose a vein closer to the heart. It's very, very important that they need to know. If that doesn't work, you follow that up. The second dose is 12 milligram. The same thing, IV push. And if they still doesn't convert back, then you go to cardioversion. You have to cardiovert them, and it's synchronized cardioversion. Make sure the monitor has the sync mode on. Otherwise, you kill them. That is synchronized cardioversion. If they come in and they are unstable, you see there were 2 stages I told you, unstable. That means the blood pressure is low, tachycardia, they already have tachycardia. They diaphoretic, they feel dizzy, they have chest pain. So chest pain, dizziness, diaphoretic, low blood pressure. That's signs of shock, okay, or acute change in mental status. These patients don't have time for adenosine 2 times. They go into cardioversion. So synchronize cardioversion. So this is why this is a passing level question, because you got to start thinking. SVT, they have SVT, and then all of a sudden they become Brady. They start having symptoms of shock. You don't have time for adenosine. You have to cardiovert them. But if they're stable, you do the vagal maneuver, go through the process, the adenosine, and then bring them back. This is another rhythm. This is a little potential lethal rhythm. This is what we call VTach. And as you can see, it's regular. It's also regular. You don't see the QRS well, but you can see the spike. You see, this is a regular rhythm. You can see they look equal. So it's a regular rhythm. Sometimes it's difficult to calculate the rate, but you can see from here to here, there's two. There's 2 bars. So probably it's like 150. I don't see any P wave, so no P wave. Right? And look at the QRS. Our QRS is supposed to be what? Less than 0.12. This one is wide. So sometimes they won't give you the numbers, they will let you describe it. So wide QRS, I don't see P wave, okay? That's VTach. And because it may be buried in this, and then the rate is very high. So this is what it look like. And it's a ventricular rhythm. So the atrium, SA node sitting there trying to fire, the pacemaker, the ventricle already doing its thing. It's keep on firing non-stop. So the impulse is coming from the ventricle. It itself is firing and causing this problem. Because of that, it caused a lot of problem to the patient. The reason why they like asking this question or they like this rhythm is VTach is there's 2 branch. If you mess it up, you kill the patient. Somebody has ventricular tachycardia, you have to do something, and that is check their pulse. Pulse. Check pulse. That's number 1. If they give you this rhythm, they said, what do you do next? So they'll give you this rhythm and then they ask you, what do you do next? Check the patient pulse, please. Check their pulse. So because there was 2 branch points. It's either they have pulse or no pulse. If they have pulse, oh, good job. If they have pulse, we have a problem. Different pathway. So let's do no pulse. So VTach without the pulse is equal to what? Ventricular fibrillation. And what does that mean? If you see that, start CPR first and send somebody to go get an AED. If the AED come, shock them. That means defibrillate them. Immediate defibrillation with 360 joules right away. That's the management. Check my other video on how to manage this clinically. I did it before this one. So it's the same thing. You defibrillate them and you give them the defibrillation is 360 joules. They won't go past that. If they giving you this kind of question, they show you the rhythm. What do you do next? Is check a pulse. And they will say, if the patient doesn't have a pulse, what do you do? CPR first before defibrillation. If there is the answer choice as no CPR, then you choose defibrillation because you need to let the heart, you don't want to apply electricity to a heart that is not moving. So that's why you do chest compression first to keep the blood pumping before you apply this amount of electricity. That amount of electricity can shock the heart and it can damage it. So CPR, even though we know we got to defibrillate them, start CPR and send somebody to go get an AED and then shock them. Even if they have the AED there right away or a defibrillator there, let somebody start CPR right away while you're getting ready and then put the machine on and shock them. If there's no answer choice, doesn't have a CPR, then I'll choose defibrillation. But you have to defibrillate them, but the first thing is to do a CPR. If he has pulse, then we have time. If he has pulse, that's another branch point. So VTach plus pulse. Then you ask yourself, is the patient stable, or unstable. Or the tachyarrhythmia, that's what you ask yourself. And if it's stable, then you give them not pain medication, antiarrhythmic to slow down the heart rate. You want to slow this chaotic heart rate. So they'll get like amiodarone or other anti-arrhythmic medication. But amiodarone, if you don't remember anything at all, amiodarone, sometimes they give you procainamide, but amiodarone is the best one. And the dose is 300 milligram followed by 150 milligram. And if they still doesn't convect, then you go to cardioversion. Synchronize. And this is synchronized cardioversion. You have to put the sync mode on. Once again, put the sync mode on. And the energy is like 50 to like 200. So 50 and 200. That's the energy. Put the sync mode on. If they are unstable, you don't have time for amiodarone. You just go to synchronize cardioversion right away. That also has a problem. You have to do a couple of things. Something they can ask you. So cardioversion is synchronized. This, they need a consent. So they can get a verbal consent. Okay. It's painful, so you got to sedate them. Sedation too. You got to tell them their heart is going to stop. Stopping of the heart. All these things you have to tell them. Okay, so it's very important you let the patient know that this is what you're going to do to them. And then before you do that. Okay, the heart is going to stop. You give them sedation. And once again, sync mode is on. That's my SATA right away. Consent, sedation, heart is educate them about it. Sync mode is going to stop right away. Okay, so that's the management of ventricular tachycardia, going to without pause, with pause, and if they have pause, whether they are stable or unstable. So that is the planning you do in your head. You're navigating a labyrinth that you have VTach. I got to check if you have pause or no pause. Okay, you have pause. Are you stable or unstable? Then I can manage you. If you have no pause, I go one way and I fix you. So that's the way to go with that. This is his friend. This is lethal, the most lethal. This is what kills people most of the time. Cardiac arrest. You see, it doesn't look like the smooth VTach that we saw. It looked like this is ventricular rhythm, but I can't make it up. It's just like all over. You don't see anything. You don't see P. You can't find. So the key feature of VFib is no P wave. The QRS is like crazy. You can't even see it. You can see it well. You can figure out what exactly is going on with it. So you don't see any T wave either. So that's the description. No P wave, no QRS, no T wave. And so the heart is not contracting, it's chaotic. Okay, it's chaotic. And look at it, it's not regular. This is irregular. There's two irregular rhythm, this one and AFib. So it's irregular rhythm. I can't even calculate the rate. Basically, the heart is equivalent. That is why they are hypotensive. So they are hypotensive and they will not have pulse because the heart is not doing anything. It's just quivering. It can no contraction at all. It's lethal. The word means lethal. You die from it. So if you see this, to defibrillate. Now, AFib, you see, I keep on mentioning because it's common. A bunch of older people have this problem. We go through our process. I need to check my rhythm, whether it's regular. From here to here, I see only 1, 2 here. From here, I see what? 1, 2, 3. That's my suspect. So I see 1, I see 2 between the arm, I see 3. Here I just see 1. So just by looking at it, you can see that it's not regular at all. Every time I see irregular rhythm, I just stop. I stop doing it. Looking at the EKG, I know it's AFib. If it's not AFib, it's VFib, but this doesn't look like VFib, so I stop. But there's some key features you can see. It's irregular. The QRS, look at it. It's normal though. And look at the name. It's atrial fibrillation. So there's a foci in the atrium that is pumping irregularly. And so you don't see true P wave. I don't see the P wave yet. These are all T wave. This is T. This is T. This is T. There's no P wave. So that's one characteristics. No P wave. Because the P wave is the atrium that is like mad. So that's another way you can remember this. If it's atrial fibrillation, I have to look at something in the atrium. What's portion of the EKG tell me something about the atrium? Is the P wave. So I'm looking at the P wave. No. If the atrium is fibrillating, then the P wave is fibrillating. Okay, that's the way you can think about it. Therefore, I shouldn't see P wave at all. It should be like zigzag, there's nothing here, no P wave. And so those are the features of the AFib. Pay attention. Treatment for AFib. Number 1, this is how they trick you. Rate control. I don't care about anything about anticoagulation. You need to control the rate. The heart rate, we can, the rhythm is not normal, so you can't use that technique. You got to count the whole thing, and then it's a little bit complicated, but the heart rate is very high. They won't let you calculate the rate. They want you to recognize that it's atrial fibrillation. So you want to calculate and decrease the rate. That's the first thing. The heart rate may be like 150, 200. You need to bring it down. So rate control. So all the medication you have that can slow the heart, okay? You can pick one. Okay, digoxin, you can pick it. Calcium channel blocker, you can pick it. Beta blocker, you can pick it. Amiodarone. So there's a bunch of medication. So if you have a SATA question, digoxin is the treatment for AFib. Calcium channel blocker, something is slowing the heart, I'm picking it. Beta blocker, amiodarone, they all can control that. After you get them out of the acute phase, you get an echocardiogram, and then you put them on warfarin. So that's later on. But that is not your choice for somebody in a hospital with AFib. You got to do what? Rate control is better than anticoagulation. They keep on tricking people because they say, oh, AFib, they're going to get stroke. Well, no, not right away. You want to slow down. If you don't slow the heart down, you continue to quiver. So you can have somebody with AFib. That's another learning point. AFib, but their rate maybe like 70. Why? Because you have them on rate control. You just lower, if this is 200, you just lower it to like 70. But you cannot affect the foci. So the rhythm will be irregular when you get an EKG. They are in AFib, but their rate is rate control. It's because they're still in AFib. That's why you give them the anticoagulation. But their rate is much better. They don't have the palpitation. They don't have the dizziness. They don't have all the symptoms. So rate control is your priority for patient with AFib, not anticoagulation. So remember, stable, unstable, the same thing. This patient is also the same thing. So if they have AFib, they're stable, I control their rate. So I give them digoxin, I give them amiodarone, beta blocker. If they're unstable, means what? blood pressure is low, they have chest pain, they have dizziness, they have paralysis. Yes. What do they do? You know the deal. Where do we go? Cardioversion. Synchronize cardioversion. So if they give you an EKG, they say, oh, this patient is AFib and he's dizzy, his blood pressure is 90/70. Yes, he's in shock, or he's complaining of chest pain, or he has changed in mental status, or is confused. I'm sending them to cardioversion. And you know how to do it. Synchronize cardioversion. So that's the management of that. That's his brother. And you can see his brother, this is R. We do the same thing, RR. And look at the RR. Just by looking at it, you can see that oh, this is even. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. So this rhythm is regular, unlike AFib, which is irregular, right? And then you look, you see P wave here, with another P wave. The atrium, you don't see that at all. The AFib, you don't see. But you see like a bunch of P waves. There's a bunch of P waves here. There's a bunch of them here. So they are not descendable, but they are there. They both have QRS that is normal. You can see there's 1, 2 bottle, 1, 2, 1, 2, and you can calculate times 0.04. So we have a regular rhythm, undescendable P waves. We have a QRS that is normal. The PR interval is difficult to calculate. This is what we call AFlutter. And look at the way they look. It looks like the atrium is an atrium problem. What do you think this look like? This is saw-toothed. You see, this is what we call saw-toothed. That's the characteristics in your test. If they give you a saw-toothed rhythm, you're looking for AFlutter. Okay, the rhythm is regular, but saw-toothed is that one. The treatment is the same as AFib. If they are stable, then you treat them with anti-rhythmic medication. So amiodarone, calcium channel blocker, all the same thing as I spoke about earlier on. You get an echo, you put them anticoagulation. They may finally need surgery to ablate the area. If they are unstable, they go into synchronized cardioversion. The same thing for them. So see the rhythm, memorize it in your head, picture it, and then keep on going through. When you go through multiple of these rhythm, you keep on flipping back and forth. You can just copy them and flip them. You can see that your brain register them. When you see it, say, oh, this is it, this is it. But then you got to do second step. What is my management? Next step. Sometimes we are not lucky enough. The rate is too low. It's slowed down. Something is blocking the SA node or the AV node that is firing. You tell them, please don't fire. So like somebody on beta blocker or calcium channel blocker, that's what they're doing. Telling them, slow down, don't fire. So we go through the same thing. You look for your RR and see if the rhythm is regular, and it look like it's regular. Okay, then you come, I see a PQRS, 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 PQRS. Then you say, oh, okay, how much is the QRS? It's almost 2 boxes. And this is like 3 boxes. So 2, 3 boxes, look, PR interval, normal, QRS interval, also normal. Then I calculate the rate between RR. I did not tell you this is 6 seconds. If this were to be 6 seconds, you just calculate, you count 1, 2, 3, 4. So 4 times 10, that will be 40. But I did not tell you that. So you calculate the big R, the small R's before this, the big line between the 2 R's, you count it. So this is 1, 2, 3, 4, 5, 6, 7, 8. So this rate is really, really low. So you have 300 divided by 8. And then, so that will give you your rate right there. So it's like 37.5. Next question, passing level question they will give you. So you have bradycardia. So is it stable? If it's unstable, how would you know? Chest pain, the same thing. I keep on repeating. There's a reason why. Dizziness, okay? Blood pressure low, confused, it's lethargic, buzzwords, be sharp. You gotta be sharp here. They need transcutaneous pacer. You have to pace them. The atropine if you have it right away, you can give it to them. But the right answer is transcutaneous pacemaker. So transcutaneous pacemaker is the treatment for somebody with bradycardia and hypotension or signs of shock. Then there's this one, the board like very much, is Torsades de Ponte, some French guy, I don't know whether he's a French, but that's his name, Torsades de Ponte. So this is, the name is something that is twisting. So twisting or meandering. It's moving around. It looks like the ventricles. You see, these are all ventricular waves. They're coming from the ventricle. But they change, they look different. These guys look different from here. These guys look, so they are called polymorphic ventricular tachycardia. They are true ventricular tachycardia, but they have different shape. How did that happen? Well, it's due to low magnesium. Low magnesium prolong the PR interval. So PR interval increases, and then it push the patient to develop into VTach. But these are polymorphic shape. So if you can draw the shape, it goes here, then it comes here, it goes down, 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 then it goes up. You see, they have different shape, polymorphic. So it look like a snake, meandering. So that's why they call it polymorphic. So this is a kind of VTach, but in a different shape. So polymorphic ventricular tachycardia. Treatment is easy. Whatever caused the problem, just give the thing to them. So magnesium IV as soon as possible to correct the problem and stop the offending agent. Usually something is causing the magnesium to be low, and that is causing this problem. So stop the offending agent and give them magnesium. That is the treatment of Torsades. But you got to remember the shape. You see, it's not like regular ventricular tachycardia. So this is regular ventricular tachycardia. This guy, they go like that, then they come like that, and they go up, up, and they come like that. So unlike VFib is doing this. This one, they go like big ventricular, wide complex. Okay. And then we have asystole, flat line. So no movement at all. There's nothing. You see, asystole patient is not doing anything. What is the treatment? So this is the two pathway when you're doing a CPR. You have VTach without a pause. You have VFib, then you have PEA and asystole. First patient, you start CPR, you check in the AED coming, and he tell you this. If he say PEA and asystole, you don't give them a shock. This is one of the non-shockable rhythm. You cure them. You continue your CPR and give them epinephrine. So this is the management. Patient with asystole, continue CPR, give them epinephrine, and go through the ACL cycle. You can check my video. It has all the detail. So CPR and epinephrine, 1 milligram. Continue CPR for 2 minutes. So that's the treatment. That's all. Asystole, CPR, epinephrine. Sometimes his friend, he has rhythm. You see, you can see this. It look normal. This is like sinus rhythm. But when you check their pulse, no pulse. So you have electrical activity. This is telling you that there is electrical activity going into the heart. So electrical activity is going into the heart. Okay? But the patient has no pulse and he's not breathing. This is what we call pulseless electrical activity, PEA. Usually this may be some thrombosis, some PE, some pneumothorax, some airway issue causing the arrest. So the treatment for this is the same as the asystole, CPR, then epinephrine, 1 milligram of epinephrine when it comes. The first thing you do is CPR, followed by medication, so epinephrine, so CPR for 2 minutes. So this is pulseless electrical activity. So the way they confuse you and trying to trick you in your question is a patient present, he's in cardiac arrest, you put a monitor in, you see this rhythm, but you check their pulse and they have no pulse. What do you do next? CPR and then give them epinephrine. Don't shock them.